We're going to move on to our second presentation.
I would like to introduce the next paper, Laparoscopic Surgery for Inflammatory Bowel Disease, a nationwide analysis of trend and outcome. The speaker is Mark Hanna.
Good morning, my name is Mark Hanna. I'm a fourth-year general surgery resident at UCI. I want to thank the Society for the privilege of presenting our work today. Oops, sorry. We have no financial disclosures, no conflicts of interest to report, and no funding was received for this study. Laparoscopic resection for IBD patients has been gaining popularity over the past decade. The reason for this is the considerable surgical burden that the IBD patients face. It's been reported in the literature that approximately 2/3 of Crohn's disease patients will eventually need a resection during their lifetime. This is in contrast to the ulcerative colitis patients, who as well receive a significant burden of about 1 in every 3 patients requiring surgery in their lifetime. Thus, laparoscopic resection has been advocated for these patients due to its superior cosmetic results, reduction in postoperative complications, shorter post-op length of stay, and better quality of life. Our study had 3 main objectives. Our first objective was to examine the frequency and utilization of laparoscopic resection for IBD patients nationwide. We wanted to compare laparoscopic resection versus open resection in the IBD patient cohort. And finally, we wanted to compare the outcomes of laparoscopic resection when subdivided between Crohn's disease patients and ulcerative colitis patients. Our study was IRB approved by both our institution and the NIS. We elected to utilize the nationwide inpatient sample. This is an administrative database that has been validated to be representative of about 95% of all inpatient hospital stays and discharges nationwide. We performed a retrospective review of all the elective surgical resections for IBD patients in the United States from a period spanning 2009 to 2012, so a 4-year period. Cases were subdivided into laparoscopic resections and then open resections, and then analysis was also stratified according to the patient's diagnosis between Crohn's disease and ulcerative colitis. Our primary endpoints were defined as the overall inpatient mortality, total charges, and length of stay. Secondary endpoints that we evaluated included a composite overall morbidity, conversion to open surgery, the risk of ileus and bowel obstruction, the incidence of an anastomotic leak, and the incidence of postoperative bleeding. In terms of statistical analysis, a p-value less than 0.05 was deemed statistically significant. We used the NIS weighting coefficient to estimate national numbers of cases of both laparoscopic and open resections. Finally, we used multivariate analysis to compare laparoscopic to open resection while controlling for multiple confounding variables. In terms of our results, we identified a total cohort that approached 9,000 resections for IBD during the 4-year study period. 2/3 of those were for Crohn's disease, and 1/3 were for UC patients. Amongst the Crohn's disease patients, 2/3 of them received an open resection, and only 1/3 received a laparoscopic resection. This distribution was mirrored in the UC cohort, where again, 2/3 of patients received an open resection, and only 1/3 of patients received a laparoscopic resection. Looking at the temporal trends in the utilization of laparoscopy, the overall rate at the beginning of the study was about 30% of all cases, so 30% were being done laparoscopically. This rate did increase slightly throughout the study period, reaching a total or a max of 35% by the year of 2012. However, as you can see, the rate of absolute increase was very low, only 5% increase in the utilization of laparoscopy over the 4-year period. In terms of the distribution of laparoscopic procedures, the most commonly performed procedure were the right hemicolectomy, and this accounted for about 30% of all cases in 2009. This did increase slightly to utilization of about 40% by 2012. The second most common procedure that was performed laparoscopically was an ileocectomy, which accounted for about 15% of all cases. However, this did decrease in utilization throughout the study period and only accounted for 10% of cases by 2012. The third most common laparoscopic resection was total abdominal colectomy, and this accounted for about 10% of all cases throughout the entire study period. Looking at the conversion rate to open surgery, we stratified the results amongst Crohn's disease patients and ulcerative colitis patients. Among the Crohn's disease patients, we had a higher conversion rate. So the total conversion rate among all the resections was about 4%, with most of these conversions happening during a right hemicolectomy or an ileocectomy. Looking at conversion rates among the UC patients, this was a lot lower. The absolute rate was only 1% of all cases. Again, this was spread evenly between ileocectomies and left hemicolectomies mostly. Looking at our adjusted results, this is comparing open versus lap resection. Looking at the Crohn's disease cohort, we were able to identify a significantly longer length of stay with an open resection. This was also significant in terms of overall charges, where open Crohn's disease resections cost about $5,000 more per case as opposed to a laparoscopic resection. We could not find any significant difference in terms of overall mortality, even though the mortality did trend towards being worse with an open resection. Again, these results are mirrored in the UC cohort, where length of stay was found to be significantly longer with an open resection. Total charges trended towards being higher with an open resection, and mortality also trended to be higher with an open resection. Unfortunately, those results were not significant in the UC cohort. Looking at our secondary endpoints, again, evaluating the Crohn's disease cohort, we found a significant increase in composite morbidity, post-operative morbidity with an open resection. This was again reflected in the rate of anastomotic leak, which was substantially higher in open resection, and the incidence of wound infection, which was again substantially and significantly higher. We did not find any significant difference in the incidence of ileus or bowel obstruction between the two cohorts, or the incidence of post-operative bleeding. Looking at the UC cohort, again, these results are reflected. So we did find a significant increase in overall morbidity that was with open resection, and a significant increase in the incidence of wound infections that was, again, higher with the open cohort. Interestingly, although the incidence of anastomotic leak trended to be higher with an open resection for UC, this was not found to be significant. Our study is limited by the fact that it's a retrospective observational study. Therefore, it can only establish associations and not causality. There is an inherent both patient and surgeon selection bias in this study that will favor laparoscopic outcomes. This is a database study, and therefore it is prone to coding errors within the database. And finally, one of the inherent limitations of NIS is that it does not track patients after they are discharged. Therefore, the study, unfortunately, is unable to comment on long-term morbidity, complications, or mortality. In conclusion, we found that laparoscopic resection for IBD patients is limited nationwide, but is increasing slowly and currently comprises about 35% of all resections. We did find that laparoscopic resection was associated with a shortened length of stay, lower incidence of postoperative morbidity, lower incidence of wound infection, and a trend towards lower incidence of anastomotic leak that was only significant in the Crohn's disease cohort. Our study did not find any significant differences in the overall inpatient mortality. In conclusion, our findings do suggest that laparoscopic resection for IBD patients is safe, it is feasible, and probably advantageous in most patients. However, these findings obviously need to be validated with prospective randomized controlled trials. Thank you.
Thank you very much. Any question?
I'll ask one while we're waiting. Can the database discriminate between a laparoscopic and a conversion? So how would a converted case actually be coded?
So the NIS uses ICD-9 diagnosis and procedure codes. So there is an ICD-9 procedure code for a laparoscopic procedure and one for open procedure, and then there's a code for a conversion from a laparoscopic to open. These codes were actually introduced recently. So in the past, This database in particular was very poor at recognizing that, but the new codes that were introduced in 2009 have been actually pretty accurate, have been validated to be pretty accurate in predicting the use of laparoscopy and the conversion to open.
So inherently, if you think that some of those converted cases may have been more difficult and they may have been coded as open, I guess my question is how the database has a very tough time with risk stratification, and that may explain those outcomes.
Yeah, that's an excellent point. That's very true. The problem with the NIS database is that it is an administrative database as opposed to something like the NISQIP database where you have actual trained coders that put in the information. So the coding errors inherent in NIS are probably going to be higher. The biases are probably also going to be higher. I should mention also that the comorbidity scores in the open cohort for both Crohn's disease and ulcerative colitis were higher, which might also explain the trend towards worse outcomes.
Yes.
Mr. Ahmed from UF Jacksonville. That was great and good number of patients, so you can tell statistical significance is there. I was wondering why people with Crohn's disease, they leak more with the open approach. Any explanation for that?
We looked at the data closely when we got the results to try to actually explain that. One of them is, and again, I didn't show this in my slides, the comorbidity of the Crohn's patients was higher. So that might explain the worst outcomes in terms of anastomotic leak. The second finding is that we just had more cases, more patients in the Crohn's cohort. So that might be the reason why we were able to differentiate the difference a little better. And thirdly, looking at the codes themselves, it seemed like Crohn's disease patients were more prone to getting multiple concurrent procedures done at the same time. So they weren't just getting a right hemicolectomy or an ileocectomy, they were getting more elaborate concurrent cases or procedures being done, and that might explain why the risks were higher.
How significant was it? You said less than 0.05. Was it 0.04, 0.03? Do you remember the figure?
I don't remember the exact number, but it wasn't strongly significant.
Okay, thank you.
Thank you very much.
Thank you.